Why is that slide not? I don't know why it's doing that. It's working good. So anyway, people talk about liver function tests, and what do they actually mean? And usually they're talking about, you go to the doctor, it's lab drawn, big metabolic profile. There are tests that reflect something about your liver. They're kind of grossly or widely termed liver function tests, but only a few actually measure the liver function, and that is specifically the measure of coagulation with prothrombin time, which you're familiar with, because the liver is what produces all your clotting factors except for factor VIII. And so that's why in liver disease you'll see the protons elevated. And also they become hypoalbuminemic and they don't have very high cholesterol, including mainly the good cholesterol, unfortunately. So those are kind of measures of that are actually measure synthetic function. I hope this isn't going to happen throughout the whole presentation. Anyway, the whole slide's not coming up. The bilirubin and ammonia, lactate and glucose are also things that are compromised. Measuring them measures kind of the metabolic function of the liver. And the most familiar parameters would be the transaminases, the AST aspartate aminotransferase, and the alanine aminotransferase, alkaline phosphatase, and sometimes gamma glutamyl transferase and LDH. So there's four main patterns that we look at when we're looking at these tests that reflect the function or activity of the liver, and that is primarily the AST and ALT, which really reflects damage to the actual liver cell, the hepatocyte. The alkaline phosphatase and bilirubin are the primary parameters that measure the flow of bile or its compromise. And again, we already mentioned the biosynthetic parameters and the metabolic parameters. So we're going to talk about the first pattern of hepatocellular injury. Again, ALT and ALT are the most frequently used. Released when the hepatocytes are damaged. Those are the normal levels. And in looking at ALT and AST, there's some more pattern recognition there. We look at the ratio of AST to ALT. We look at the level of elevation and the rate of decline to get an idea of what's going on with the patient's liver. More specifically, ALT, more specific for the liver, primarily is an enzyme in the cytoplasm, very long half-life. A little bit is found in muscle, kidney, and heart. The ALT, it is more widely distributed in addition to the liver, also being found in heart, red cells, muscle, kidneys, pancreas, brain, and lung. It's primarily a mitochondrial enzyme, and a little bit is in the cytoplasm. So, why is AST higher than ALT in liver disease? You may have heard that usually it's a 2-to-1 ratio, and there's two reasons for that. That's because alcohol causes a vitamin B6 deficiency, which decreases production of AST, or decreases ALT, and also mitochondria poisons alcohol poisons the mitochondria, where the majority of the AST is located, so thereby increasing this level. So here we go with looking at the ratios. most of the liver disorders will have a ratio of AST to ALT of less than 1. The ones that, and there are probably more, but these are some of the primary ones. Alcoholic hepatitis, generally, that's the 2-to-1 ratio or greater that you always hear about. Generally, the elevations in alcoholic hepatitis are less than 300, but it can be higher. And then there's a few other things that can cause that. Biliary obstruction, ischemia, cirrhosis, and Wilson's disease, which is a copper excess because the liver can't handle the copper, can't excrete it. Now, the level of elevation tends to give you a clue as to what's going on. And there's 3 categories, basically. And you'll see some variation in the literature, but generally, severe if your ALT is greater than 600, moderate, 200 to 600, and mild. What I'm going to tell you about mild and moderate is almost everything's included. So it doesn't really help you a whole lot knowing that it's a mild to moderate elevation. But these are some of the things that you need to think of. First of all, of course, medications. Medications not only can cause hepatocellular injury and elevation of AST and ALT, it can cause a number of other patterns of liver injury, including cholestasis and a number of other ones. Alcohol, chronic viral infections will cause AST, ALT in this range. Hypothyroidism, interestingly. Adrenal insufficiency, and also pretty common, you'll see patients with heart failure. They have passive congestion of the liver. Now this is probably the most important slide, and I'm sorry the red didn't turn out too good here. But severe, when you see very high elevations of ALT, that helps you probably the most in terms of diagnosis. Acute viral hepatitis, acetaminophen overdose, and acute ischemic hepatitis, shock liver. The ischemic hepatitis will happen when somebody's septic, or they have an MI, and their blood pressure tanks, and it's 60 or 50 for a long period of time, maybe hours, and then in the next 2 to 3 days, you're going to see huge transaminase elevations, like in the 3000s. And then you're going to, with that history, you know it's ischemic. But everything in this column can cause severe ALT and AST elevations in the thousands. So when you see that, you will think, the first thing you should think of is ischemic hepatitis, acetaminophen in particular. You've got somebody that drinks a pint of whiskey a day, and all of a sudden, I took about 6 or 8 Tylenols for some belly pain over the past few days. They come in, and they're in thousands. It's acetaminophen toxicity. Sometimes they come in late, and the liver enzymes are normal. And the acetaminophen level is normal. And they come in, a few days after the fact. Everything could normalize by then. You still have to treat. You can still save their liver if you treat with the acetaminophen, IV glucose. The protocol for that. We do that a lot here. So these are the things that can cause severe elevations, not quite as, maybe some can cause it in the thousands, but these are the primary ones. Autoimmune hepatitis, fulminant Wilson's disease can, Budd-Chiari syndrome is an important one. That's thrombosis of the whole hepatic vein you see with a variety of conditions. Important not to miss that one. You need to do some kind of imaging, like a ultrasound with Doppler or CT with contrast if they can tolerate it to see the occlusion. And then finally, the third thing we look at when we're looking at AST and ALT elevations is the rate of decline. If it declines pretty fast, this is going to tell you that these are some of the main conditions that cause fast improvement in those parameters. Ischemic hepatitis being the main one. Slow, any drug with a long half-life. Acute viral hepatitis is sometimes slow to resolve. Autoimmune hepatitis certainly is. And then metabolic disorders. Okay, so now we're moving on away from hepatocellular injury to the cholestasis type of injury to the liver. And the primary parameter or test that monitors kind of the flow of bile is alkaline phosphatase. Physiologically, which means normal, the alkaline phosphatase is elevated in these groups. Elderly, there's a gradual increase with age. There's a very high elevation of alkaline phosphatase in children and adolescents because of the bone growth. And pregnancy, because alkaline phosphatase is found in the placenta. And people with blood group O, that's not a huge increase, it's small. And certainly after eating a fatty meal. And then you're all familiar with the pathologic increases in alkaline phosphatase, bile duct obstructions either within the liver or outside. So the normal level for alkaline phosphatase is about 20 to 70, half-life is 7 days. It's, like I said, it's found in the liver, the bone, gut, kidney, and placenta. And in the case of biliary obstruction, the reason the levels become elevated is that actually the obstruction actually induces the synthesis of alkaline phosphatase. These are some of the pathologic causes. For intrahepatic, you can have drugs that cause intrahepatic cholestasis, cholestasis of sepsis. Any infiltrative liver disease can cause, compression of your bile ducts within the liver. Cancer will cause liver tumors. And then primary biliary cirrhosis, which is an autoimmune disease, which attacks the bile ducts. And then sclerosing cholangitis, which is an inflammatory disease that causes scarring of the bile ducts, usually associated with ulcerative colitis. I think we've seen a couple of patients in the past few months that had liver transplants due to sclerosing cholangitis. Yeah. And extrahepatic is very, most people are familiar with that. Gallstones within the lumen of the bile duct, the common bile duct. And outside the bile duct, compression from cholangiocarcinoma, which is a bile duct carcinoma. And obviously any metastatic lesion can do it too, such as pancreatic cancer, swollen lymph nodes, and gallstones can cause extraluminal compression. There's a thing called Morisi syndrome, and that is where a gallstone gets stuck in the neck of the gallbladder, and that intrinsically compresses the common bile ducts from outside the common bile duct. I don't have a picture of that, but anyway. So now moving along to the biosynthetic function. Like I said, all of the coagulation parameters are made in the liver except for factor VIII. The proton and INR are dependent on these factors, and the ones in yellow, 2, 7, 9, and 10, are the ones that are vitamin K dependent. So when the liver's synthetic capability becomes impaired due to the alcohol damaging the hepatocytes, it can't make these factors until your blood becomes thin. And there's also probably a component of vitamin K deficiency as well, in addition to that. Merely on the basis of malabsorption and malnutrition, because vitamin K is produced by bacteria in your gut. And alcoholics know that they just drink, or they get all the calories. So now, bilirubin, one of the key parameters for metabolic function. You can look at it as a determinant of the liver's ability to clear endogenous and exogenous substances from the circulation. We measure 2, indirect or unconjugated bilirubin, which has been processed by the liver. I think I got that backwards. Not processed by the liver, elevated with hemolysis. Yeah, sorry about that. And then direct or conjugated because it's been hydrolyzed by the liver, so that it's made so that it can be excreted. The slide, sorry for the incorrect slide there, but it's elevated clearly with biliary obstruction and even hepatocellular disease, right? Because you damage the hepatocytes, they swell up, and then you get compression of the bile ducts in the liver. So, and jaundice generally occurs when your bilirubin, noticeable jaundice, when the bilirubin is greater than 3 milligrams per deciliter. You can really see scleral icterus, though, at a much lower level, probably 1.5, something like that, if you look at the patient carefully. So I'll go back over that. Sorry for the error there. The indirect has not been processed by the liver. Think of hemolysis when you see that one. And that, when you do the actual lab work, they measure total bilirubin and direct bilirubin. So the difference is the indirect. Direct bilirubin is measured and reported on your lab report, and it's the one that is conjugated, processed by the liver. So more on the cholestatic pattern. What else can cause intrahepatic occlusion of bile ducts or compromised bile ducts? Anabolic steroids, certain contraceptives, antibiotics like like Zosyn, for example, can cause a cholestatic picture. But there are numerous drugs that can cause a cholestatic picture of liver injury. TPN can cause a cholestasis. And viral hepatitis and alcoholic hepatitis